So hello everyone, lovely to see you all here. Thank you so much for coming along, and thank you Annika and CPM for hosting me here today. I'm Leah. I'm a doctor training in general surgery with a particular interest in breast surgery in New Zealand. And last year I completed a Masters of Global Health Science and then went on to work in the Centre for Personalised Medicine. And today I'll present mainly this qualitative evidence synthesis, but also a little bit of background from some previous work I've done with my thesis as well. So my talk will be in two parts. Briefly, part one will be about some of the background literature in a New Zealand context, and then part two will focus on the qualitative evidence synthesis that I did here with the Centre for Personalised Medicine. So beginning with part one, so the New Zealand context for breast cancer. So New Zealand actually has one of the highest incidences of breast cancer in the world. We have an age standardized rate of 93 per 100,000 population, which is almost double the average rate of 56 per 100,000 population in other countries with high human development index. This is not the only public health issue with respect to breast cancer, though, that we face. This high incidence is further compounded by significant health inequities, and that's been my area of interest in terms of prior research I've done. And these health inequities disproportionately affect Indigenous populations and also those living in more deprived areas. And I'll just illustrate a couple of these inequities for some context. So this graph depicts the 10-year breast cancer survival by ethnicity. And you can see there are significant inequities by ethnicity there, where Pacific people, that's the dark blue line, and Māori people, that's the yellow line, have significantly inferior breast cancer survival. And key contributors to this inequity have been shown to be deprivation and also reduced access to healthcare. The inequities also extend when we consider time to treatment for breast cancer. And this is some work I've done previously, which looks at time to surgery for early stage breast cancer by ethnicity in New Zealand. And you can see on this forest plot that both Māori and Pacific in fully adjusted models have significant delay to time to surgery compared to New Zealand European women. And similarly to the other disparities I've mentioned, this is also contributed to mainly by increasing deprivation among these women. So we'll just park that for a moment. This moves me on, so kind of the segue to the second part of the talk. And we all know that screening programs serve to benefit populations by detecting disease early so that we can have prompt treatment and survival can be improved. The other benefit that screening also offers that's kind of less known about, I suppose, is that screening significantly reduces health inequities. And so if we turn back to the two inequities I mentioned, there's a huge survival benefit for Māori and Pacific people in New Zealand when diagnosed through screening, such that difference I demonstrated on the graph before essentially disappears if you look only at women diagnosed through screening. And also there's no longer any differences in time to treatment if we look just at the woman diagnosed through screening versus all of the population. And so this kind of highlights the importance of screening. Not only does it benefit the whole population, but it can significantly reduce health inequities. However, engagement is very low in some groups. And in New Zealand, that tends to be women living rurally and also ethnic minority groups. And so this kind of background context led me to think, why is that? And that's kind of what prompted the inspiration, some of the motivation for the qualitative evidence synthesis that I'll now go on to talk about. So moving into that. So the research questions for the qualitative evidence synthesis that we undertook were, firstly, what are the barriers and facilitators to engagement in breast cancer screening? And secondly, given knowledge of all these ethnic inequities, is the data diverse? So I'll now talk through the methods, some key results and findings, and some potential future steps. So for this review, we developed this search strategy with consultation with a health sciences librarian. There are, broadly speaking, 3 groups of terms for the search. So those relating to breast cancer screening itself, those relating to barriers and facilitators, and finally those relating to qualitative methods. And we chose to do qualitative methods so that we could get detailed, richer, descriptive elements, hopefully from a patient perspective, rather than extracting numerical data. And we searched the two databases displayed, so PubMed and the Cumulative Index to Nursing and Allied Health Literature. And that latter journal was chosen because it has a particularly heavy focus on qualitative literature. This is the inclusion and exclusion criteria for our review. So we included studies, as I mentioned, that reported qualitative or mixed method studies. The articles were all in peer-reviewed journals. Women had to be eligible for breast cancer screening, and by that I mainly mean breast cancer screening age, and also be women who do not currently or recently had a breast cancer diagnosis, as those women would be under surveillance rather than screening for breast cancer. We were only really interested in the patient-reported factors rather than perspectives from, say, policymakers or healthcare professionals, and all the studies were published in English. We excluded studies based on breast cancer diagnostics, because this is about screening, and also excluded studies with quantitative methods. So here is the PRISMA flowchart after we ran that search. So there were over 2,000 studies imported initially, and after duplicates were removed, there are a total of 1,578 studies, which underwent abstract screening. After application of the inclusion-exclusion criteria that I showed you before, over 1,000 were excluded, such that there were 493 articles which underwent full text review. Following that, a further 356 were excluded, and the reasons for that are displayed up on the screen. Most commonly, it was because when we read them further, it was actually quantitative methodology. And essentially, in the end, we ended up with 137 papers included in this qualitative evidence synthesis. This is just a shortened version of the data extraction form that we use to extract data from each of the papers. Just highlight some of the key aspects that we extracted. So study name, study aim, sample characteristics, the type of screening being studied, whether that's mammography or self-examination. For demographics, we used a framework called the Progress Plus tool, which I'll introduce on the next slide. And then importantly, we obviously extracted information around barriers and facilitators to engagement in screening. And then we also extracted strengths and limitations of each study. So this is the Progress Plus framework that we use to extract the demographic data. And this is a framework recommended by Cochrane Methods when trying to facilitate equity in systematic reviews. And essentially it's considered the sort of bare minimum demographic diversity data that should be included in any published paper. And so Progress stands for place of residence, race or ethnicity, occupation, gender and or sex, religion, education, socioeconomic status, and social capital. And then the plus kind of relates to other factors that weren't necessarily relevant to this review. Before I move on to the results, I'm just going to introduce the COM-B model, as this also informed a key part of our methods. So the COM-B model is a model of behavioural change, which is based on the principle that in order for any behaviour to happen, such as attending screening, the individual needs to have the capability, the opportunity, and the motivation for that behaviour to happen. And it's further broken down a little bit, and I'll just talk you through that so that you can understand methods and then results. So each of those three categories are further broken down into 6 sub-constructs. So capability can be a physical capability or a psychological capability, such as knowledge. Motivation can either be a reflective motivation, so that's like a higher cognitive functioning, such as your intentions or your goals and your reasons for doing something, or it can be an automatic motivation, which tends to be motivations that are more outside of our awareness, such as impulses or unexplained emotions as to why we might do a certain behaviour. And then opportunity can be broken down into physical opportunity or social opportunity. These are then further broken down into this theoretical domains framework. And this is the most important part, as this informed our methods. Essentially, I'll show you the results soon and some examples soon, but every barrier and facilitator that we extracted was recoded against one of these theoretical domains. And this was done by 3 reviewers independently going through all of them to match each facilitator or barrier into one of these categories. And we chose to use this framework, one, because it's used elsewhere in the literature when exploring barriers and facilitators to engagement in screening programs, and also because it serves as a way to match potential interventions to these specific categories. And I'll get to that a little bit more shortly. So here's just some examples before I move on to the results. So these are four barriers extracted from one specific paper. And then it shows the way they've been coded. So the yellow is the 6 subconstructs that I mentioned, and then the pink is one of those 14 theoretical domains, the more granular detail there. And important, I suppose, to note the last one has been coded twice. And so each barrier or facilitator could be coded more than once. So there is some overlap between some of these categories. They're not limited to one category. So I'll move on to some of the key results from this project. So first of all, this is just a rough and ready map of the global representation of the 137 papers. Initially, it looks like there's quite a good global spread, but if you look more closely, that is predominantly the global north. And when you actually look at the numbers of the 137 studies, the majority are from America, the UK, and Australia. And all the other countries shown tend to only have 1 or 2 studies from them. Obviously, this doesn't factor in population size, but there is still a predominance to the global north from the studies that were included. So moving on to answer research question 1, which, just to recap, was what are the barriers and facilitators to engagement in screening? So this table here displays all of the barriers and all of the facilitators mapped to the theoretical domains framework from the COM-B model, and I've just got that there as a reminder. So a few things to point out. So first of all, you can see there are 1,065 barriers extracted and 480 facilitators extracted from the studies. And I personally think that's an interesting finding in itself, that there's over double the number of barriers reported in the literature than there are facilitators. And initially I wondered if that was a reflection of the study methodology. But when you actually go back and go through, because we've recorded the study aim, when I went back through and looked at that, the majority of them are seeking to find both barriers and facilitators. So I don't think that necessarily represents a bias in the methodology. And so I do think that's an interesting finding. And then in terms of common categories, so the most common category for both barriers and facilitators was physical opportunity, environmental context, and resources. And then some of the other common categories highlighted there. So knowledge, social influence, and emotion, just for barriers. And these are just some more examples with quotes to match them. So, and how they would have been coded. So a barrier that's reported is the belief that mammograms do not always detect cancer. And there's a quote from a patient or participant to support that. And that's the way that would have been coded as knowledge or misconception. And then there's some other examples there. So moving on to the second research question, which was, is the data diverse? And this is a table displaying the frequency of diversity data reporting in the 137 studies using that progress framework that I talked about. So overall, you can see that the diversity data reporting is quite limited, and it's interesting to note that not a single study reported all of these factors, despite the Cochrane guidelines saying that this is kind of the minimal diversity data that we should be reported on, and not a single one reported across all of these. Place of residence and with scores highly, that's just the country the study was done in. It doesn't necessarily include granular detail around that. And initially, race and ethnicity looks to be quite well reported at 87%, but when you actually look back at some of those studies, the level of detail around race and ethnicity is quite limited. And doesn't actually go into much more granular detail for that. So the 87% there is kind of falsely saying the data is diverse in terms of race and ethnicity, but it's not necessarily when you look in more detail. And then you can see for the other factors, the reporting percentage is very low. And this lack of diversity data to me is quite concerning, because we saw at the beginning, using the New Zealand context, that there are minority groups who are disadvantaged, and these minority groups are actually shown to be less likely to engage in screening. And so with this lack of diversity data in the literature exploring why this might be, there are still some invisible groups who are not being studied, and they're probably the people less likely to attend, and we don't have any literature to tell us why. So I think this is a concerning finding overall. So those are that's kind of the key results for each of the research questions, but I'm just going to focus on some kind of key findings or messages that we've taken from this review. And these are kind of the three themes I'll talk around. So the context matters, why the literature might be widening disparities, and finally why new methods are potentially needed. So the context matters. So barriers and facilitators were often decontextualized. And by that, I don't just mean that there was a lack of diversity data. I've already talked about that. But often the barriers and facilitators, despite being a qualitative review, were merely written in a kind of table or list-like format without exploring like wider cultural or social factors that might contribute to why that factor is a barrier for an individual. And this meant there was often quite a narrow lens of analysis. And a useful example that was recurring in the literature is cancer fatalism. This was a frequently reported barrier. Cancer fatalism is the fear that a cancer diagnosis is fatal and results in end of life. And this was often just written as that, cancer fatalism, without exploring the context for why someone might have adopted that view, in particular the social influences as to why they might believe that, and as well as the wider cultural factors. And so in general, it felt like the lens of analysis was quite narrow, despite there being a breadth of literature on this. And so the problem that I've identified from this review is it's not that there's a lack of literature. There are 137 papers that we looked at, which is quite a lot, but it's just that there was a lack of depth in the way these papers conducted their analysis. And the problem with this is that decontextualized literature can risk decontextualized solutions, and because of course the solutions are different depending on the context. And this poses a big issue, I think, for health policymakers and people wishing to introduce interventions to improve screening. Because if the wider diverse data has not been considered in the design of these studies, then interventions are only going to benefit those who are studied, while again leaving a marginalised group that haven't been studied, and potentially we don't know what the barriers and facilitators are for those people and what the context is. And this is a graphic that essentially presents that problem. This is published last year in a paper called the Contextualization Deficit. And this model essentially, in short, is saying that science or research informs policy, and policy then informs societal impacts, and then that goes back to inform science. And this can go around in two directions. And the lilac circle, can we come up lilac? Yeah. Represents the spaces of contextualization. So it's saying that the context in which the science is done informs the context in which the policy is done, which then informs the context in which the society has impact. And the important thing to note is that part of the science circle is shaded outside of the lilac, saying that there's some science or some literature, some context that we're not considering, and those are not able to influence the policy and therefore not able to have the societal impacts. And so that's the concern here with this review, that there are invisible groups that have not been studied, and therefore interventions or policies are not going to benefit those groups. Yeah. So moving on to a second thread or theme. So there's some concern that the literature might be widening or might reflect widening disparities. So screening by definition is a population health measure that aims to benefit a population to improve health on a population level. But it may be that it's actually only benefiting some people. And this is something a theme that came up kind of outside of the COMBI analysis, and that's that the meaning of health is quite different for different people. And it kind of broadly falls into two groups from this review. And that's the kind of concept of being healthy means being free of disease, or being healthy means being proactive. And here's some examples to kind of show how that fits in with the screening program. So if I'm healthy, I'm healthy if I do not need to attend the healthcare centre. So why would I go and get a test? Versus health to me is being proactive and finding out early. And you can see how these differing perspectives would influence whether as an individual you wanted to attend a screening program. And so it may be that already screening programs are selecting for certain groups on those with a perspective that encourages being proactive and encourages attending screening. Something else we noticed in terms of potential disparities is that a single factor, so the same factor, could serve as a barrier or facilitator for different groups. And the examples where this was quite recurring was in around social influences. So for some groups or some individuals, social influences such as being a mother or your role to your children or your duty at work was a motivator to attend screening. Whereas for others, this served as a barrier because it prevented the freedom or the time to go and engage. And religion was another factor which could also serve as a barrier and facilitator. And this concept of one factor serving as both of these also applied on an individual level, in particular with regards to women wanting a personalised medicine experience. And this came up quite a lot in the literature, that the idea that women want to feel that their experience is personalised and they're welcomed when they first arrive to the screening, that then when they are going through they're exposing their breasts, they want modesty and they want things to feel depersonalised. And the reason I think this is important is that some interventions could potentially widen disparities, because if you design an intervention around a factor that's a facilitator for one group, but it's a barrier for the other, the health disparity will potentially be widened. And then I'll just move on to why I think potential new methods are needed. So as I've alluded to, most of the methods don't explore the wider context or include diverse data. And there's a paper that's referenced there that suggests that one potential way to overcome this when looking at screening or looking at behaviour change relating to health is that perhaps we need to move our model, our methods away from prediction. That's the idea of how do we make it more likely that people will access screening, and change it more towards understanding the preceding conditions or the preceding reasons. So why a woman not attending? And although that seems quite subtle, the paper talks about why that may allow a more contextualized approach, because it takes a step back and again looks at the wider context and the reasons for individual choices. And potentially new methods could use threads from this study to target a more diverse inclusion group. And so that takes me on just to some future steps, just to sum up. So turning back to the interventions, so with the COM-B analysis, there are interventions that you can match to each of those categories. But it's easy to look at that and think the easy solution would be, for example, education and increasing access to screening. But I think a lot more than that is needed. Because it's well documented in the literature that educating people is not a clear, easy solution. You know, if we could educate everyone, then everyone, if it was as simple as that, then everyone would be healthy. And so one potential future step that may, I think, increase engagement is whether we could reframe what a screening program is. I wonder if how we talked about it could potentially change people's motivation to attend, and particularly if we think about those differing perspectives of what health means for different people and how reframing that might benefit some of those groups. But in summary, I think the interventions remain a work in progress, given that the data in this review was not particularly diverse. And essentially the study has shown that a greater context or diverse approach is needed first. So in summary, we've identified a number of papers with over 1,000 barriers and 480 facilitators. Knowledge, environmental context and resources, social influences and emotion were the most frequently reported domains. As I've said, there's a breadth of literature, but a lack of depth and diversity. And the concern was this, is that decontextualized data risks decontextualized solutions. And without context, those who already benefit are potentially likely to benefit more, while invisible groups will experience greater disparity. And that is the end. Thank you all for listening, and thank you for the opportunity to talk. And thank you in particular to Annika, Lisa, Farah, and Joseph who have helped with this review.